Good morning, everyone. Today I will be presenting a study on critical appraisal of a differential diagnostic study. So, going into the study, so I look at a case scenario. A 54-year-old gentleman presents to medicine OPD with complaints of recurrent episodes of hemoptysis with weight loss for the past 6 months. So, he had history of contact with the TB patient at home 2 years back. The PG register evaluates for TB, which he thinks is the most common cause. However, AFP smear and expert TB sputum comes negative, and chest X-ray done does not show any significant findings. So he thinks of other causes and plans to evaluate further. However, the patient, due to financial and time constraints, wants to go back home. What would you advise the patient? Would you advise him to evaluate further, or would you start him with ATT, considering TB as the most probable cause? So to answer this question, I went through the literature and I found a study in which they have looked at patients who are presented with hemoptysis, and yet this was a 5-year study using the French nationwide hospital administrative database. So I have used JAMA critical appraise guidelines for appraising this study on differential diagnosis. So going into the PICOT statement, the patients were people more than 18 years of age admitted with hemoptysis. So as it was not this study did not have any intervention or a control arm, the outcome which they looked at was etiologies of hemoptysis, and the timing of follow-up was they followed up patients for a period of at least 1 to 3 years. The study design was a retrospective cohort study, and the setting was done in France. A nationwide hospital medical information database was used to do this retrospective cohort study, and was done from 2008 to 2012. So going into the critical appraisal questions, so the study patients represent the full spectrum of those with this clinical problem. So to answer this question, to look at whether they are represented the full spectrum, you need to look at two things which are mentioned. One is the clinical problem as such, and also the clinical setting, and whether the entire spectrum was involved or not. So going into the clinical problem is not defined clearly, because they had mentioned patients had presented with hemoptysis. However, whether the patient had a single episode or multiple episodes of hemoptysis at presentation, they had not mentioned. And whether the patient was admitted with hemoptysis or whether a past history of hemoptysis was also taken into consideration was also not clearly defined. And also, how did they exclude patients who had presented with other causes, like whether they had presented with an epistaxis, which was wrongly diagnosed as hemoptysis, or whether they had upper GI causes contributing to hematemesis, which was picked up as hemoptysis, was not clear. So there was no clearly defined definition for hemoptysis in their study. Another thing is the clinical setting of collection. So they had taken all the patients who were admitted in the French and Asian administrative database, so which gives us information about all the hospitalized patients. So obvious from what they have said that they had taken only the hospitalized patients. They did not take a proportion of patients who were probably directly discharged from the emergency department. And information which they had collected were mainly from the ICD coded discharge summaries. So if they had mentioned in their study that in France most of the hospitals have an ICD coding system and all the discharge summaries are coded. However, whether there is any hospital with no proper recording would have gotten excluded from the study. And also they had searched for this hemoptysis as either they had mentioned hemoptysis as one of the main differential associated or related diagnosed in the ICD coding, or whether the etiological causes which they had taken was mentioned in the ICD diagnosis. So if the hemoptysis was either not recorded in the ICD coding or its etiology was not recorded, that was not taken into consideration, and those patients are probably excluded. Other thing is whether this had represented the entire spectrum of severity of cases which they had taken. So like considering to our hospital, if the patient had presented with some other problem and had developed a minor episode of hemoptysis in the ward which was not very significant according to the treating physician, it might not have come in the ICD coded discharge summary, and probably those mild cases would also have been excluded when they taken the cases. So hence the study patient probably did not represent the full spectrum with this clinical problem in their studies, what I thought. Other thing is, was the diagnostic evaluation definitive? So to see whether the diagnostic evaluation was definitive, so like I mentioned, they had taken a list of etiological diagnosis for patients presenting with hemoptysis. So they had taken tuberculosis of the lung, larynx, trachea, bronchi, bronchopulmonary neoplasms, vasculitis, thoracic trauma, pulmonary embolism, anticoagulant usage, vascular malformations, respiratory infections. So they have taken a significant list of things which we would also see in our clinical setting. However, few things which were not included, which I felt was pseudo patients presenting with pseudo hemoptysis, whether they had aspirated blood from the upper airway or GI sources and presence like a hemoptysis. That those was not included. And patients who had bleeding disorders or platelet disorders or disseminated intravascular coagulation probably was not included. And drugs and toxins causing hemoptysis like cocaine, bevacizumab treatment, argemony alkaloid treatment was not included. So these were the things which I felt were not included in their set of ICD coded diagnosis. And whether they had actually looked at whether the diagnostic evaluation was fully definitive, so it is probably not, because like I mentioned, they had only taken diagnosis as it is mentioned in the ICD coding system. But however, how they have arrived at that diagnosis, whether there was any diagnostic algorithm which is followed, or whether there was a standardized diagnostic approach which is followed, which is not mentioned. And as you can imagine that the entire data was collected from different hospitals in France, which might be primary, secondary or tertiary care settings, and all the different hospitals might be following a different diagnostic algorithm, or there was not a standardized diagnostic approach which is probably followed, and that was also not mentioned in the article. Other thing is, for each of these ICD coded diagnosis, there was no diagnostic criteria which was mentioned for detecting the individual cases. So how they said a particular patient is having pulmonary TB or patient is having vasculitis. That diagnostic criteria for that individual disease was also not specified. And finally, when they followed up these patients, among 50% of the patients had a cryptogenic cause for hemoptysis. That means around half the patients, they did not arrive at a diagnosis or etiological cause for them developing hemoptysis. So that is also a significantly higher number, which was also a drawback which I considered for the study. And they followed up these undiagnosed cases for a period of 3 years to find out whether they are developing another, or whether they can find out another diagnosis later on. And that also, like considering hemoptysis as a problem, whether 3 years was sufficient or not for following up these cases, whether they should have had a higher follow-up. So that is also another thing which I felt maybe they could have followed up for a period of slightly more years to find out whether they were developing some other, whether they are developing new symptoms and getting diagnosed as another, probably a bronchopulmonary carcinoma and all later on in their life. So those were the things which I felt that which was not done properly, and the diagnostic evaluation was not definite. So they had mentioned in their study that since 2008 to 2012, they had used a significant amount of interventions, like they had done thoracic surgery, flexible fibroscopy, rigid bronchoscopy, endobronchial intervention, and CT scans. However, whether these modalities were used for diagnosis of the cases or as a therapeutic intervention was not specified, and whether this was used in an algorithmic approach or whether there was any specific criteria which they followed for using for patients, as in which patient presenting with this, whether they would use CT scans or endobronchial intervention was not specified. Now going into what were the diagnosis and their probabilities which they arrived at. So total hospitalization per year in France, they had recorded as 10 million, and patients among that, around 15,000 of patients is getting admitted for hemoptysis. So incidence and prevalence of hemoptysis, like incidence means new hemoptysis cases which they see when they followed up patients were around 15,000. And the prevalence of hemoptysis, like patients with chronic hemoptysis, were probably around 15 to 16,000. That they mentioned. And when they looked at the etiological distribution of hemoptysis from 2008 to 2012, as you can see from 2008 till 2012, every year around 50% of the patients has been diagnosed with cryptogenic hemoptysis, like I mentioned. That means around 50% of the patients, they did not arrive at a etiological diagnosis at the end. This is followed by respiratory infections and bronchopulmonary malignancies. So, if a patient presents their hospital during this period of time, there is a 50% of presence their hospital with hemoptysis, 50% of chance that patient would not have a diagnosis at the end of their evaluation. And around 17 to 18% of the patients, if the patient present with hemoptysis, will be diagnosed as having a bronchopulmonary malignancy. So when you actually come down and you look at lung tuberculosis, which is one of the most significant things that you would see in a setting like India, they only had a 2 to 3% of patients who are diagnosed with lung tuberculosis. So, so they are not reported as a probability, but however, when you add all these things in each of the years, this will come to total of 100%. So the percentages which they mentioned is probably the probability of patients having that particular diagnosis. However, they not mentioned any confidence interval for this frequency percentage which they had mentioned. And they had also followed up these patients, and they have looked at patients who had developed recurrent hemoptysis and also patients who had been followed up later on. So when they looked at the cryptogenic and respiratory infections, 10% of the patients in each arm, like patients who were initially diagnosed as cryptogenic or respiratory infections, later on developed a bronchopulmonary malignancy when they had been followed up. And patients who had developed a recurrent hemoptysis since 2008 and 2009, when they had followed up for a period of 2-3 years, they had found that most of the patients still were on the cryptogenic arm and they had developed a recurrent hemoptysis, but a significant proportion of the patients had lung cancer, which was diagnosed later on when they had come with recurrent hemoptysis, which is followed by respiratory infections and bronchiectasis. So, how precise are the estimates of disease probability? So, they have not reported a confidence interval for disease frequencies they have published. So, precision we cannot determine without a confidence interval. So, as we can say, like if they say that 48.9% or 23% of the patient had respiratory infections, if there is no confidence interval, we can't say like up to how low that percentage can go and up to what higher level that percentage can go. Without that, we really can't say whether we have confidence in those estimates which they have mentioned. So they have not mentioned a confidence interval, so precision could not be determined. So coming to our setting, like a setting like India, our study patients have clinical settings similar to mine. So I would say that it's not similar because France is a developed country and India is a developing country. So the etiological diagnosis which they would have would definitely be significantly different from a developing country like India. And also the clinical setting, when we look at our hospitals also, we don't have a standardized diagnostic approach or algorithm for patients presenting with hemoptysis to get a diagnosis. And ICD coding was also not universal in India. Not every hospital followed ICD coding. So because of that, the clinical setting was also different. And India is also a developing country, so the clinical setting is significantly different. And a major proportion of patients probably does not seek healthcare if they develop a single episode of hemoptysis or is empirically treated for TB if the initial testing is inconclusive in an Indian setting. So, like I mentioned, in a developing country like India, TB still contributes to a major proportion of the patients compared to lung cancer. So, the clinical setting is significantly different. And is it unlikely that the disease probabilities or possibilities have changed since this evidence was gathered? So, it is definitely likely that the disease probabilities would have been changed because now we have newer methods of diagnosis which are being utilized currently for diagnosis, which are bronchoscopy, EBUS biopsy, PET-CT guided biopsy, expert ultra for detection of tuberculosis. With these newer methods of diagnosis, the disease probability would definitely significantly change. And other than this, the baseline itself the setting was different from our setting. So, in the developed countries, based on studies, acute bronchitis, bronchitis, and bronchial neoplasms are the most common diagnoses which they arrive at patient present with hemoptysis. In contrary to a developing country like India, when they have infection due to mycobacterial tuberculosis, Paragonimus westermani, or non-cystic fibrosis-related bronchiectasis are the diagnoses which they would arrive at in a country like India. So the probabilities of the possibilities are also different, and now we have newer methods of diagnosis which would maybe probably lead to a more significantly different diagnosis, etiological diagnosis post such a study. So coming to my case scenario, I would advise the patient to get evaluated further due to the possibility of other causes like bronchogenous carcinoma, considering his age. But my patient, the initial investigation was inconclusive. So if he is not willing for further treatment or further evaluation to look for other causes like a bronchogenic carcinoma, I would start him on empirical ATT, considering that is the most common cause still for hemoptysis in developing countries like India. Around 70 to 80% of the patients presenting with hemoptysis gets diagnosed as tuberculosis, and the symptoms resolve with starting of ATT. However, I would keep the patient under close follow-up and monitoring to watch for improvement in his weight as well as improvement in his symptom. And if he is not improving later on during close follow-up, he is developing any other symptom, then I would decide to evaluate further at that point of stage. So, considering this study, going to a clinical setting like India, the setting is significantly different. So, whether I would use such a study to change my practice in my clinical setting, I would say probably not, because the clinical setting was initially different, as well as the study itself was done in the significant flaws which I felt was noted in the study. Like they did not mention the clinical problem or the definition of hemoptysis. Later on, they not they not done a proper diagnostic evaluation, and that was also not clear. The algorithm was not there, and also there was no confidence in the estimates which they mentioned. So because of all these, I would not use this study to change practice in my setting. But however, if a patient presents with, if I have to go look at what would be the probabilities in country like India, I would probably choose to do a different new study in the Indian setting to find out that. But however, it will be definitely challenging, considering like how they had mentioned, there was a retrospective cohort study and they had ICD coding in the summaries and all. So it will be difficult to do in a broader setting in different hospitals, because we need to have a standardized diagnostic algorithm and a treatment plan for diagnosing these patients. But in a setting like CMC in a single institution, it would be worthwhile to do such a study. We can form a diagnostic algorithm and a treatment protocol for patients presenting with hemoptysis, and based on that, probably maybe we can consider finding out what are the most probable diagnoses which we are arriving at, and based on that, we can make a decision on what to do when patients present with hemoptysis.